Hello everyone, my name is Einat Blumfield and I'm a pediatric radiologist from the Children's Hospital of Montefiore in the Bronx, New York. I will talk about imaging findings in multisystem inflammatory syndrome in children associated with COVID-19. New York City experienced a heavy burden of COVID-19 during the spring of 2020. Most cases of severe illness and mortality of COVID-19 occur in the elderly and in patients with comorbidities. In children, the disease tends to be milder, and many children are asymptomatic. However, in April 2020, a new syndrome of severe multisystem inflammation with features similar to Kawasaki disease has emerged in children. It was first reported in Europe. At the same time, children with similar symptomatology appeared in New York, and the syndrome is now known as MISC, Multisystem Inflammatory Syndrome in children. By the end of May, 176 children were reported in New York State. From mid-April until mid-June, 38 children with MIC were admitted to our hospital in the Bronx. The clinical presentation of MIC consists of persistent fever, GI symptoms, as well as mucocutaneous manifestations. Many of the children progressed rapidly to multi-organ injury and shock. The affected children typically have markedly elevated inflammatory markers, and interestingly, most reported children were previously healthy. We reported 16 children that were admitted from the end of April until the end of May. Of them, 10 were males, and the age range was between 20 months and 20 years. In our study group, 9 patients, 56%, had comorbidities. Most commonly, they were obesity and asthma, which are common in our study population. All 16 patients presented with fever. Other presenting signs and symptoms included GI symptoms that were common, including vomiting, diarrhea, and abdominal pain, as well as mucocutaneous manifestation, including rash and conjunctivitis. Headache and sore throat were seen in some of the patients, and shortness of breath and cough were seen in only 1 patient each. 11 of the patients had positive IgG for SARS-CoV-2 and 4 were positive for PCR. All patients had elevated inflammatory markers and D-dimer. All patients had low albumin levels, and most had elevated liver enzymes. 6 of the patients had elevated troponin, and 5 exhibited laboratory findings of acute kidney injury. Interestingly, 6 patients were discharged from the emergency room 1 to 3 days prior to their admission, as they did not seem to be sick enough to be admitted. However, during their admission, 11 of the patients, 63%, required ICU admission. Only 1 of them needed intubation and mechanical ventilation. 10 of the patients developed hypotension or shock. We evaluated thoracic imaging findings of these patients, and echocardiogram demonstrated abnormalities in 13 of the patients. Of them, most common were systolic myocardial dysfunction, which was seen in 10 of the patients, and ectatic coronary arteries that were seen in 4 patients. In chest radiograph, the most common findings were cardiomegaly and congestive heart failure or pulmonary edema, as well as atelectasis and small pleural effusion. ARDS was seen in only 2 patients. Evaluation for pulmonary embolism was done in 8 patients. Of them, 6 had CT angiogram and 2 had VQ scans. And in 2 patients, CT angiogram demonstrated segmental pulmonary embolism. This is a 7-year-old boy with history of sickle cell disease. His first admission radiograph demonstrates his baseline cardiomegaly. On the second day of admission, his heart has increased in size and he developed pulmonary edema as well as left retrocardiac atelectasis. This is a 14-year-old, previously healthy. His admission radiograph was normal. On the second day, he developed bilateral opacities consistent with adult respiratory distress syndrome. His heart has enlarged. He developed retrocardiac atelectasis as well as a small left pleural effusion. This is a 6-year-old girl, and in her CTA demonstrated a filling defect in a segmental artery to the left upper lobe, consistent with pulmonary embolism. Abdominal imaging findings were also evaluated in abdominal radiographs, ultrasound, and CT scans these patients had. And most common findings were small ascites and hepatomegaly, which were seen in 6 patients each. Echogenic kidneys were seen in ultrasound in 5 of the patients. Bowel wall thickening and gallbladder wall thickening were seen in 3 patients each. 1 patient had urinary bladder wall thickening, 2 patients had mesenteric lymphadenopathy on CT, and 1 patient had splenomegaly. This is a 5-year-old boy, and his abdominal radiograph demonstrates hepatomegaly, which can also be seen on the sonogram as the liver extends far below the lower pole of the kidney. He also had small right pleural effusion marked by the white arrow. This is an 8-year-old girl that had laboratory evidence of acute kidney injury, and we can see that the right kidney is echogenic and is more echogenic than the liver. Her gallbladder demonstrates significant wall thickening and edema on ultrasound. This is a 14-year-old, and on this CT scan, we can see marked by the black arrow multiple enlarged mesenteric lymph nodes and thickening and enhancement of the colonic wall marked by the white arrows, as well as ascites, small ascites in the pelvis marked by the white arrowheads. The abdominal radiograph was performed 1 day after the CT scan and demonstrates retention of contrast in his kidneys. He as well had evidence of acute kidney injury on laboratory evaluation. On the abdominal radiograph, we can also see the thickening of the colonic wall marked by the white arrow. When we combine the imaging findings in the chest and abdominal modalities together, we found that 12 of the patients had cardiomegaly, 75%, 10 patients, 63% had pleural effusions, and 10 patients had atelectasis. With regard to management and outcome, in addition to supportive measures, anticoagulants, and vasopressors as required, 10 of the patients received intravenous corticosteroids, 5 patients were treated with intravenous immunoglobulins, and 2 patients received anakinra, which is an interleukin-1 antagonist. 15 of the patients, the vast majority, were discharged home after they improved, and their lengths of hospital stay ranged between 3 and 20 days. There were no mortalities in our study group. In conclusion, MISC is a newly described syndrome associated with COVID-19, which likely reflects a delayed immune-mediated response. The patients typically present with fever, GI symptoms, and mucocutaneous manifestations, and may progress rapidly to multi-organ injury predominantly involving the cardiovascular system. Pulmonary manifestations are distinctly uncommon, unlike in COVID-19. Thoracic imaging findings are predominantly secondary to myocardial dysfunction and include cardiomegaly, congestive heart failure, pulmonary edema, and small pleural effusions, and frequent abdominal imaging findings include ascites, hepatomegaly, and echogenic kidneys on ultrasound, reflecting the underlying multi-organ inflammatory process. Imaging may play an important role in suggesting diagnosis of MISC, as the initial clinical presentation may be non-specific. Pediatric radiology should be aware of the constellation of the imaging findings, which, although non-specific, when combined with the clinical presentation and with history of exposure to SARS-CoV-2, should suggest a diagnosis of MIS-C, as the patients may rapidly deteriorate. While most admitted patients with MIS-C are severely ill and require admission to the ICU, the vast majority improve clinically with appropriate management. Thank you very much for your attention.